Thank you so much for joining our 4th annual of the International Day of Women in Statistics and Data Science Conference with this year's theme, Thriving in Your Environment. We are recording this event and the video will be available on the Caucus for Women in Statistics and YouTube channel. We kindly ask you to post your questions in the speakers and Q&A chat. Without further ado, I'm delighted to host this session on advancing real-world data research in Asia-Pacific practice and opportunities. So, meet the panelists. So we have 4 panelist speakers today, joining from Japan, China, Hong Kong, and Australia. So, introducing myself, I'm Hong Kong. I'm a researcher in pharmacoepidemiology area with a degree in pharmacy, followed by around 7 years of experience in handling databases across Asia, mainly in Hong Kong and Japan. Gina, do you want to introduce yourself?
Yeah, hello everyone. Thanks, Wally. And hello everyone, I'm Jingnan Li, a principal statistician at Eli Lilly, China. I work primarily on real-world evidence research, post-marketing safety studies, and medical affairs publications across therapeutic areas of autoimmune diseases, neuroscience, and diabetes. It's a great pleasure to be part of this panel discussion today.
Kate, do you want to go ahead and introduce yourself?
Yeah, sure. Hi, I'm Dr. Kate Miller. I'm based in Perth in Western Australia. I work for the Population Health Research Network, also known as the PHRN, which is one of Australia's premier national research infrastructures. I'm an epidemiologist by trade, specialising in linked data in the area of infectious diseases and type 1 diabetes.
Okay. Shirley, have you joined the session? Okay, maybe I'll introduce Shirley. Shirley is an assistant professor at the University of Hong Kong.
Yes.
Okay.
Let's go ahead.
Yeah, go ahead.
Hi, everyone.
Yeah, so she, yeah. So Shirley is an assistant professor at the University of Hong Kong, jointly appointed by Department of Medicine and the Department of Pharmacology and Pharmacy. Her research mainly focuses on HTA, health economics, and real-world data evidence using decision models and electronic medical records. She specializes mainly in healthcare data analytics, cost-effective modeling, and health policy evaluation, and has led numerous HER projects in collaboration with academic institutions, government, industry, NGOs, and key opinion leaders. Thank you so much. Thank you all joining for our session today. So today's agenda will be focusing on 3 different topics mainly. One is starting with like different type of real-world databases across APAC region, and we'll be introducing case studies in each region, and followed by talking about key challenges and opportunities in the RWD area. So I'll be starting with the Japan real-world database. So this is actually one of the latest databases taken from ISP, which is International Society of Pharmacoepidemiology. So currently there are around 20 real-world databases in Japan. 8 of them are hospital-based and insurance database. Here we have 3 examples: MDV database, JMDC database, as well as MIGNET. So MDV and JMDC are the largest administrative claims databases, mainly in Japan, used mainly for a lot of RWE studies. So MDV database covers around 53 million of population, hospital-based, and around 25 million people in the insurance database. The data actually has a really long traceability, about like more than 15 years, I would say, for both MDV and JMDC. And this database is mainly used for incidence, prevalence, or any other long-term disease trends and all of that. So finally, Midnight is a relatively new database. This is a hospital-based database mainly used by the Japan regulatory authorities for post-marketing surveillance studies only. And since this is a relatively new database, the population coverage is actually only up to like around 5 million people. The data is actually taken from only 23 hospitals across 10 organizations. Since this has a lot of laboratory test data, so this is really useful for any sort of safety assessment and all of that. Moving on to China, real-world database, Jinan, do you want to take this?
Yes, thanks, Wadi. The landscape of real-world databases in China can be somewhat different from Japan and maybe many other countries and regions. But I'd like to note that the insights I'm sharing today are based on my experience working within a pharmaceutical company and may not fully represent the broader landscape of real-world data in China. So we work with various types of real-world data in China, including electronic health records, EHR, disease registries, and occasionally claims data. For EHR data, there are several large-scale national databases. One example is the National Cancer Center Oncology Database, which is currently the largest oncology database in China. It aggregates medical records from major cancer and general hospitals across 27 provinces. And in addition to national databases, there are many regional EHR databases that focus on multi-center EHR databases that focus on specific geographic regions. So the case study I'll be sharing later will be based on one such regional EHR database. And when our research focuses on a specific therapeutic areas, we often turn to a disease registry databases. So these registries can be used both in retrospective and prospective real-world studies. And for instance, we used to run a post-marketing safety study using the credit platform, which is the Chinese Registry of Rheumatoid Arthritis. And claims data may be used for drug compliance study and health economics research, but to be honest, we don't use it that often here as in our company. And the databases we work with cover a wide range of therapeutic areas, and they vary in terms of region, population coverage, and clinical focus. So each comes with its own strengths and limitations. Therefore, when designing real-world studies, a key step for us is to identify the database that best aligns with our research objectives. That's pretty much for China real-world database.
Thank you. Maybe Shirley, do you want to talk about Hong Kong real-world database, CEDAS database?
Okay, thank you, Swati, and thank you for the panelists for giving me this opportunity to share information about Hong Kong database. So Hong Kong's real-world database, we're mainly using electronic health records. So this is a territory-wide electronic medical records managed by the Hospital Authority of Hong Kong. So it basically covers all the public hospitals in Hong Kong, which is 7 clusters, 42 public hospitals. And all the eligible citizens have the access to this hospital, and that means historically the database already covered 11 million of population so far. And since the CEDAS has been established in the year of 1993, this is a centralized database that can link all the clinical relevant information, including the demographics, prognosis and death registry, and also all the diagnosis, laboratory tests, procedures, prescriptions, and also radiology results. So this database is very powerful, and it has been established since the year of 1993. And then the follow-up can be done until yesterday. So it's a good data sources to study population level medication outcome research, and including a safety, effectiveness, and also some cost effectiveness, long-term outcomes. And the paper publication-wise, since the data has been widely used in researchers in Hong Kong and also in Asia Pacific area, so far CDS has published more than, I think, at least 1,000 publications. I didn't do statistics, but the representatives and data quality has been shown in the existing literatures. Thank you.
Thank you. Thank you, Shirley. Maybe Kate, you want to talk about Australian real-world database?
Yeah, thank you. So in Australia, we don't have a national electronic health system that's been universally adopted. So most of our real world data that we use comes from what we call administrative data sets. So that's data that's routinely collected as part of the delivery of a service, and it's usually either required or authorised by law. So this diagram here just gives you some of the examples of the real world data sets that are available to our researchers. As you can see, huge amounts of data are collected across the course of a person's lifetime, as well as across a broad spectrum of sectors well beyond health. In Australia, our health data is owned by both state and federal governments, and the data is collected and managed at both levels, and it often needs to be combined to be able to conduct national analysis. So state and territory governments are responsible for data that's collected within their health systems, so such as hospital records, for example, while key federal bodies collect and manage Commonwealth data, such as like your Medicare, medical claims data and your pharmaceutical data. So for many of our health research questions, the real world data that we need doesn't all sit within the one data collection. And so instead we need to be able to link together multiple data collections to be able to get all the information required. So in Australia, we rely quite heavily on data linkage. So the method of bringing together records from different sources but relate to the same individual or event. So we've built dedicated data linkage units that serve each of the states and territories throughout Australia, as well as a national data linkage unit. And they link the data between the different data sources in ways that preserve individuals' privacy. So we have almost 200 administrative data sets that are routinely linked within the Population Health Research Network. The regularity of the linkage differs by data collection and jurisdiction, so it can kind of range from monthly to annually. However, we also do ad hoc linkage for data sets for specific projects. So for example, the clinical trial data that you can see there, the clinical registry data and survey data. Temporal scope of the data, that also differs by data collection and jurisdiction, so it's not as clean as those electronic health records that we see with some of the earlier panelists. Some of the data goes all the way back as far as 1868, but for the most part, the linked data is available nationally for the last 20 years. And then private hospital data is a little bit more recent than that. But one of the challenges of the administrative data is that they're not designed for research. So researchers are really restricted to the information that's collected for administrative purposes. So they can't customize the data collection. And then another difference, I guess, with the electronic health records is that they often lack the kind of complex clinical performance-based and imaging measures. And that can obviously make it difficult to evaluate treatment effects or identify key prognostic factors or adjust for some of those important confounders, which can make it difficult to try and detect those subtle differences between intervention and control groups or understand the heterogeneity of treatment response. So our researchers will often link real world data with trial specific data, for example, to try and fill those gaps and allow for more comprehensive analysis. Thanks.
Thank you. Thank you so much. So we'll move on to talking about different applications of these real-world databases and how this is used in the HER area. So I'll be talking about one of the typical case study application of RWE. So when a new drug is launched, so we can use real-world databases to see what are the characteristics of patients who are receiving this drug, as well as any treatment pattern, for example, treatment discontinuation pattern or any adverse event or any dose modifications and all of that. So this is one of the typical examples where we describe the real-world use of abemaciclib for the treatment of early breast cancer in the earlier days of after launch. So this was a retrospective cohort study using MDV database spanning from 2008 to all the way up to 2023, especially in the earlier days of post-launch after abemaciclib for early breast cancer. So the population was any patient with early breast cancer who received a prescription of abemaciclib, and we identified around 374 patients. So there are around, the patient was majoritarily female and had a median age of around 54 years, which is typical of any early breast cancer in Japan. And one of the key interesting findings that we observed in this study was around 13% of the patients were chemotherapy naive before receiving, while receiving abemaciclib. So typically, abemaciclib is recommended as the second line or third line. So we expect them to have any sort of neoadjuvant chemotherapy or adjuvant chemotherapy. So this is one of the key interesting findings in the study. We also identified what are the concomitant endocrine therapy that is being used in this population, which is tamoxifen and letrozole, and as well as anastrozole was observed to be the main concomitant endocrine therapy with abemaciclib. And also around 40% of the patient had dose reduction. Unfortunately, with MDV database, since it's an administrative claims database, you cannot assess the reason for any dose reduction or if there is a treatment discontinuation or anything related to that. So this study mainly provided data informing how patients are being prescribed abemaciclib in Japan, as well as what is the treatment pattern in the clinical practice. Moving on to a case study from RWE application in China. Jinan, do you want to take this?
Yes, thanks, Wally. And now I'm going to share another case of RWE application in medical affairs. So it's a study presented at the American Diabetes Association conference earlier this year. So as we all know, diabetes remains a major public health challenge globally, and of course in China. And cardiovascular diseases are among the most common complications in patients with type 2 diabetes, and that sometimes are associated with considerable morbidity and mortality. So, and in China, the Chinese Diabetes Society recommends a hemoglobin A1C target of less than 7.0 for most non-pregnant adults with type 2 diabetes, and 6.5 or less for selected low-risk individuals. Additionally, maintaining a normal BMI, which is less than 24, according to China cutoff, is considered an important component of comprehensive diabetes management. However, there is limited consensus on the BMI optimal BMI threshold and its combined impact with glycemic control on major cardiovascular outcomes. And also long-term real-world evidence addressing this question has been scarce. So for this study, we conducted this real-world study to investigate the association between glycemic control, normal weight, and the long-term 3-point major adverse cardiovascular events, which is 3P MACE, in patients with type 2 diabetes in China. Next page, please. So this study, as I mentioned earlier, this study is based on the regional EHR database, and it used patient data between the year 2006 and 2021 from the Regional Health Information System of Yingzhou District in Ningbo City, China. This system integrates multiple data sources, mainly including the electronic medical records, but also includes health examination data, medical insurance claims, and immunization records, and death surveillance data. One thing about the database that I want to highlight is that in 2021, data for patients with diabetes and hypertension were in this database were standardized using the Observational Medical Outcomes Partnership, that's OMAP common data model. So one of the key reasons we selected this particular database was its high level of completeness and data quality. I won't go into too much details about this study, but we included about 5,757 patients with type 2 diabetes and with at least 5 years of follow-up time. So we used Kaplan-Meier method to generate cumulative risk curves among different groups of patients. And we also use Cox model to assess the association between a normal weight, a normal BMI, and normal BMI plus glycemic control and the risk of 3P MACE, which include myocardial infarction, stroke, and cardiovascular death. For those cost models, we adjusted for relevant demographic and clinical characteristics. So as shown here, we did achieving the normal BMI at baseline and muting dual targets, that's normal BMI and glycemic control, regardless of whether HbA1c cutoff was less than 7 or equal less than 6.5 was significantly associated with a reduced risk of 3P MACE. So these findings actually underscore the importance of maintaining both glycemic control and a healthy weight in the management of type 2 diabetes. And also it provides real-world evidence to support medical affairs in scientific communications and clinical decision-making. So that wraps up my example of how RW can be leveraged to support medical affairs. Next, Shirley will share a case study that highlights how RW can drive impact beyond clinical decision-making.
Thank you. Shirley, you want to take this?
Okay, thank you, Swati, and thank you, Jiannan, for the introduction. So now I'm going to share our real-world evidence case 3. This is about how we are using a combination of real-world data and also decision analytic modeling to make biosimilars into the public formulary. So this is gonna be a showcase that's showing how the data is powerful used for the reimbursement decisions. Our sharing case was published by JAMA Network Open last year. So it's about a cost effectiveness of biosimilars versus lufeninib in patients with arthritis. Next slide, please. So the method is going to be very detailed. So the objective, the disease focus, we're working on arthritis. So patients with rheumatoid arthritis, they usually suffered from long-term disease burden, loss of productivity, and they do have unmet needs for the novel disease modifier treatment, such as biologics or small synthesized new treatments as JK inhibitors. However, biologics originators, they are quite expensive. So the healthcare system has suffered from introducing this to the public formulary with considerable budget impact. However, given the development of biosimilars, we see there is a new hope that patients maybe have the new treatment access through these biosimilars, which is supposed to have the same bioequivalent effect in terms of same safety and efficacy profiles. So to fulfill the purpose of evaluating the cost effectiveness of biosimilars, we have developed a disease simulation model to mimic the disease progress of patients with arthritis. So according to the current guideline, if patients is diagnosed with arthritis and they fail the first line standard treatment, which we call metronidazole, which is a conventional synthesized DMARS, and then the patients will have a few choices. Either they choose bio originators. In Hong Kong, they have to self-pay, or they add on another conventional synthesized DMARS, which called lufeninib. So the study actually want to evaluate whether biosimilar can be used early, so as a replacement of the combination therapy. That's our objective. So to fulfill the purpose of disease simulation modeling, we need a few parameters to put into the model. Then the model can forecast the cost and health benefits of different treatment arms. So to make this summary of the parameter source, we have the study population profiles, which is from the CDS database we just introduced. So this is from arthritis cohort with localized demographics, patient profiles, and their treatment patterns. So this is from CDS managed by the hospital authority. For the transition probability, this is the most important parameters of the simulation model. So basically, the transition probability will mimic the patient journey while they enter into different stage of disease severity or death. So the transition is linked to the treatment of intervention itself. We have a mixture of data source, including the landmark trials and also the real-world data. We use the real-world data to understand the discontinuation patterns of our patients and their probabilities of having a side effects, assuming biosimilars is the same as biooriginators. Yes, so this is the transition probability information source as a quick tell. And the quality of life in terms of utility is also an important measurement in the model. So it's because of the data set is not perfect. We don't have any patient-reported outcomes, so we use the clinical trial data to feed the model to represent their quality of life. And the cost is definitely from CDS. So each health economic evaluation have to be localized, reflecting the local healthcare systems, treatment patterns, treatment cost, costs related to adverse events, and also non-pharmaceutical treatments. So in summary, population profiles and cost is very local. We use CDS information. And the clinical benefits as transition probability and quality of life, we use a mixture from clinical trials and also real-world evidence. So next page, please. Now we come to the results. So the decision analytical modeling is quite complicated, and this is the most fancy part, and I'm too proud to show here. So this is the sensitivity in terms of 10,000 iterations of Monte Carlo simulation. So we're not doing one trial. So this is, you can consider this as 10,000 of trials. And then even we try this through different uncertainties of the parameter inputs in terms of the cost variations, the transition probability uncertainties, the quality of life uncertainties, etc., etc. However, the model gives us consistent results that the two biosimilars we're testing are cost-effective comparing to the conventional therapy. So the willingness to pay is the general term that we use for health economic to determine which one is cost-effective or not. And in Hong Kong, because we don't have such guidelines, so we adopted WHO guideline to use one local GDP per capita to determine it is cost-effective or not. So the conclusion is inclined that biosimilars, particularly for adalimumab biosimilar, is not only cost-effective, but also cost-saving, which means it's cheaper and also give you better health return. So considering all these potential financial and clinical benefits, next page, please, Swati. So we have published our paper. We also do press release to educate the general public and also the decision makers to let them know, oh, this is data-driven evidence that's showing biosimilars is cost saving. So the healthcare system should really, really consider to adopt these into the public formulary. And upon our efforts, the public formulary in Hong Kong has enlisted these two biosimilars last year, Q4. So now it's highly reimbursement from the hospital authority. So all the patients with arthritis fulfill the indication, they can access this treatment without extra payment. Yeah, thank you. So that's all my sharing. However, as I mentioned, we do have limitations from our own electronic medical records because it's basically for clinical management. We don't have such information as patient-reported outcome, quality of life, and so far we don't have a lot of record linkage yet. We only linked to death registry, but not to the social wellness or the quality of life. So that's why I think Kate's sharing later on is going to be very important and very interesting. So let's introduce Kate's sharing. Yeah.
Thank you so much. So as I mentioned earlier, the Population Health Research Network is a research infrastructure, so we don't conduct research ourselves. So the case studies that I'm going to be looking at today have been conducted by Australian researchers who have accessed the PHRN infrastructure to access real-world data sets. So we use real-world data for a range of purposes to measure disease epidemiology and explore the social determinants of health. We support site selection, identify at-risk populations, looking at the number of eligible individuals who meet particular criteria within a given jurisdiction. We look at data longitudinally, so it allows us to look at healthcare and pharmaceutical use both pre and post intervention. It could be useful for surveillance and monitoring of safety and reporting of adverse events. We use it for primary and secondary endpoints such as hospitalizations and deaths. And then also looking at the long-term effects of different treatments, vaccines, measuring healthcare utilization over time. We have really good data collections around payment and cost information, which can really support robust health economic evaluations, and we can also use it to measure the representativeness of trial participants. But the two case studies that I'm wanting to look at today are really looking at that real-world application of a vaccine after it's been implemented into a national vaccination program. So as I mentioned before, this isn't my own research. I am presenting it on behalf of a researcher. So this first study, the human papillomavirus vaccine, as we know, is a really powerful tool for the prevention of cervical cancer. So the HPV vaccine was introduced in 2007, and Australia was the first country in the world to introduce the vaccine into its publicly funded vaccination program. So it was developed by industry based on really critical research that was done using real-world data at the University of Queensland in Australia. So the method of this study, so it was a case control analysis of real-world data to measure the effectiveness of the quadrivalent human papillomavirus vaccine against cervical abnormalities 4 years after implementation of the nationally funded vaccination program in Queensland, Australia. So the participants included women eligible for free vaccination. So they were aged between the ages of 12 and 26 years in 2007 and attending their first cervical smear test between April 2007 and March 2011. So the real world data sets that were used included the vaccine registers to the pap smear register. So we have mandatory reporting of vaccinations in Australia. So the data sets are both complete and high quality. The pap smear register, however, is an opt-out registry, but it still is estimated to contain data for up to 99.5% of all Queensland women participating in the cervical screening program. So using real-world data via these administrative data sets really allowed this study to avoid some of the reporting and selection biases that can occur in interview-based studies. And the inclusion of both school and community-based catch-up programs really enabled this study to have a quite comprehensive evaluation of the effect of vaccination with adequate power to assess outcomes. Limitations relying on administrative data did mean that researchers were only able to control for a limited number of covariates in the analysis, and misclassification of exposure status in some women was likely to have occurred just due to some inaccuracies in the vaccine register data, as well as those arising from actually linking the data itself. But it's expected that that's very low. In terms of the finding, the study found that the HPV vaccine conferred statistically significant protection against cervical abnormalities in young women who had not started screening before the implementation of the vaccination program in Queensland. But really understanding the role of the HPV vaccine in cervical cancer, and then the success of the vaccine have now resulted in a change to the cervical cancer screening program in Australia. So cytology screening every 2 years for women aged 18 to 69 years has now been replaced with HPV screening every 5 years. So this program is predicted to be much more accurate and also cost effective and less intrusive for women. Next slide, please. So studies across the world similarly found that the HPV vaccines were really highly effective at preventing precancerous cervical lesions when given in a 3-dose schedule. So this next study that we're looking at now really looked into whether 1 dose of the HPV vaccine was as effective as the original 3-dose schedule. Some post hoc trial data had suggested that 1 dose prevents HPV infection, and obviously if 1 dose could prevent precancerous cervical lesions, and global cervical cancer prevention would be greatly facilitated. So this study used linked registry data from all 8 Australian jurisdictional cervical cancer registers with the National HPV vaccination register, the National Death Index, and each of the state cancer registries. So the study included all women in Australia aged 15 years or under when eligible for vaccine, who screened between April 2007, which is when the vaccination commenced, and the 31st of December in 2014. And so using these real-world data sets really allowed the researchers in this instance to adjust for confounding factors such as socioeconomic status and area of residence. The study found that 1 dose had comparable effectiveness as 2 or 3 doses in preventing high-grade disease in a high coverage setting. And it concluded that 1 dose vaccination may be a viable strategy when working towards global elimination of cervical cancer. And then in 2003, the Australian Technical Advisory Group on Immunisation recommended that HPV vaccine schedule move from 2 doses to a single dose for most young people. So I think it's nice to finish off with a really nice example of seeing how that real world data can really translate into policy and practice. Thank you.
Thank you. Thank you so much for sharing different cases and cases in real world, ranging from descriptive studies to application real for hospital formulary listing in medical affairs, as well as looking into different policy applications as well. Now we'll talk about key challenges and opportunities for collaboration in RWE. So Kate, do you want to talk about the linkage between administrative database as well as hospital-based clinical data in Australia and how it's being done?
Yeah, sure. So as I mentioned before, the privacy preserving techniques that we use are really critical. We use what we call a separation principle. So our data custodians, we don't have a national identifier number in Australia. So we conduct our linkage using names, addresses, and dates of birth. So each of our data custodians send identifiers to the respective data linkage unit, and they use those identifiers to see if the person exists in the system. If they don't, they create a new linkage ID, and if they do, they add that particular record to what we call a unique linkage identifier, which is an alphanumeric code. The content data with the custodians is kept completely separate from the identifier, and then when it's released to the researcher, the content data is attached to that unique identifier rather than the person's individual identifying information. So it is a complex process, but it doesn't allow us to provide researchers with content data without those identifiers attached to it.
Thank you. Well, linkage is very much, pretty commonly done. And Kate also mentioned that the data actually spans from 1980s so onwards. So this is pretty well established in Australia, but may not be the case in other countries. For example, in Japan, administrative claims databases as well as hospital databases are linked. But there are a lot of limitations if a patient moves from one hospital to another. Certain populations, certain databases, you cannot trace them across hospitals. But in Hong Kong, that's not the case. So maybe Shirley, maybe can you tell about like linkage between different hospitals and within CEDA's database?
Thank you, Swati. Thank you for promoting CEDAS. I think CEDAS, the beauty of CEDAS establishment is that it highlights patient privacy. So initially, all the researchers we won't touch any of the patient identities, and the IT team from hospital authority, they already masked these patients with a unique identifier we call reference key. So using this reference key, each patients will have the same reference key, regardless of which country or which hospital they will go for. And even they go for family medicine, GOPC, are still using the same reference key that we can identify these patients. So I think that's why CEDAS has shown its advantage of linking all such informations together, regardless of patients is changing the clusters, they're changing the living address, they can still using their Hong Kong ID and then directly link to the de-identified reference key that is for researchers to trace their clinical outcomes. And this can happen since the year of 1993. So we basically knows what happens of these patients historically. And through the initiative of COVID-19, that period, a vaccination program, the government has commissioned Hong Kong U to do the vaccination surveillance, safety surveillance. So in that exercise, we indeed has linked the vaccination records with the patient outcomes. So it's because it has been managed by different sectors. Department of Health is managing all the vaccination exercise, and then the hospital authority will have all these outcomes. If the patients experience severe safety events, they will come to the hospital and then they will have a record. And then in that time, it's because the vaccine has been launched due to emergency use. And there is a very strong government commission that we do population-wide surveillance. And that time, the record linkage has been conducted by hospital authority. The Department of Health has passed the vaccination records to hospital authority, and then they do the record linkage and mask the patient information again and release the data to researchers, so that the big data analytical team can do the real-time surveillance. That's our experience of sharing. So definitely stay positive. Linkage is doable. Yeah, so we just need some techniques, and then we need a trusted third party to protect our patient privacy. And then, yeah, it's once we identify it, it will become a very powerful tool of research. Yeah.
Definitely. So I think linkage maybe in China as well. What's the current scenario? Jinan, can you maybe shed light on this?
Yes, it's a linkage. It's definitely a big challenge in China right now. So as I mentioned earlier, we chose that Yingzhou database for that study. Is one reason is that in that certain area, the linkage is actually was done pretty well. So the data was relatively complete so that we can really get the long-term outcomes of those patients. But when it goes beyond a certain area, because China is so big, so and those data between different even different like cities or provinces, it will be so hard sort of to connect them. And like patients, they might not go Kate or Shirley mentioned that people may go to different hospitals maybe just for that one condition. But as far as I know, it's just really it's such a big challenge when it goes beyond a single region. Or like for larger area, the linkage is very challenging. But because I work in pharmaceutical company, we basically just find the database that works best for us. As far as I know, we don't except those few like national databases. For other data, we don't really have that many databases that the linkage so well. Like when it covers the area larger than a single region. Yeah, so I guess there's a long way to go for this kind of for the linkage part. Yeah.
Yeah, that's a huge population, a huge country. So, handling all the data is certainly, linkage, and even having a database covering all the population would be pretty much nearly impossible. So, yeah. Talking about standardization of databases, there are a lot of common data models that could help, sort of bring together different databases and help run analysis in parallel and make database comparisons and everything easier as well. Maybe if you can talk about standardization of databases in your country.
Maybe I'll go first. Yeah, we do have some collaborative research working with the other collaborators from Asia Pacific and also globally. I think the major challenge is that we're dealing with different structure of database. And then the database, the scope of database, variable namings is very different. Sometimes language is also an issue. So we have two strategic ways to deal with this. The most straightforward way is we're using standardized data. We're using research data protocol method. So that's very straightforward. You don't have to worry about the data structure. All the collaborators or investigators, we confirm the research protocol. Okay, this is the research question, hypothesis, detailed method. We agree with each other. Okay, we comment and then we share this protocol. Then our research team is running the analysis according to this standardized protocol and then generate results. Then we pull the results together. So this part we
Is there some technical issue?
Hello?
Yeah, I can't hear Shirley
can.
anymore.
No.
Maybe.
Yeah.
It seems, Shirley, are you still on the call?
I can see.
Okay, maybe Gina and Kate, do you want to talk about, data sharing and collaboration as well as standardization of databases in your particular regions? We have only two to 3 minutes left to go. Around 4 minutes before we take questions from audience.
Dinan, did you want to go first?
Yeah, maybe I can talk a bit about the standardization of databases.
Yeah.
So as far as I know, there are a few regional databases in China that currently have started or developed or sort of complete part of the standardization of databases. And the challenges Shirley shared earlier were also was similar to what Shirley suggested, as far as I know. So what I learned so far is that some databases will choose to do some of the sort of start with some of the chronic disease patients first. Like I mentioned in the case study I shared, for that specific database, they started with hypertension and diabetes patients data standardization, because since they're like the population, because that's actually a sort of rich area in China, so that the population there is relatively steady. stable. So the resident in that area won't move that too much. And then they, as they have chronic diseases, they will go back to hospital for regular visits regularly. So it's easier for those this kind of cohort to be standardized. But then for other population, I heard that the challenges can be bigger. So I know there are people still working on it, following that standardization that to follow, like for example, OMAP to follow to make the variables and data structure exactly as that data center. But I mean, for now, as I haven't really heard that much progress beyond the diabetes and hypertension population, but I guess it's a long way to go. Yeah, and maybe Kate or Swati, do you want to?
Yeah, so we do have what we call a national health minimum data set. So that's a core set of data elements that a national agreement mandates be collected and reported for health services. So that data is used for creating performance indicators or supporting national health agreements and allowing for a kind of consistent comparison of healthcare safety and quality across different organisations and levels of government. So yeah, that allows for consistent uniform data collection at a national level for reporting and analysis. But these elements, however, are limited to what's actually available at a state and territory level. So it's only a proportion of the full, hospital data collection for example, that might be available from the hosting state. And then I guess the other challenge is that they're not available for all of our administrative data sets and also not across sectors, so not outside of health. So we definitely still have room for improvement there. One of the challenges that we have really comes from the data being owned and managed by both state and Commonwealth governments. And then even within that, individual data collections are owned and managed by different data custodians, and they each have their own kind of privacy laws and data governance frameworks that really regulate how their data can be used and who can access it. So that can make the approval process quite complex and time consuming. And restrictions on data sharing can limit access to certain types of information and also to kind of certain parties such as commercial organisations or international researchers.
Thank you so much. I think we have reached towards the end of our allotted time. So maybe let's take questions from audience at the moment. Okay.
I think there's one, actually two questions.
Okay. So I see a question from Dr. Jyoti asking about what are the organizations in the country that manages these databases and how many people are employed for this purpose. So maybe Shirley, do you want to talk about CEDA's database, and let's talk about individual region, who is governing these databases and how many people are being employed for this RWE purpose.
So do you mean the coverage of population of the database itself?
So mainly, I think this is the question says how many people are employed for this purpose. So maybe I think it will be really difficult to answer the second question though. So maybe let's talk about what are the organizations in each one of these regions that manage these databases.
Oh, okay. So for us, for CEDAS, it has been managed by the hospital authority, IT team, and also statistical team, depending on the request from researchers. So they have centralized the clinical management system, all the individual-based patient information into the big databases, that including everyone, and then also do the de-identification exercise. And yeah, so I don't know how many people I really managing all this database, but there are different ways of getting access to the data. So you could submit your request to the data custodians from hospital authority. Then they will figure out, according to your research protocol, they will figure out the data, and then they do the ethical approval, panel assessment, and also the expert panel assessment agreement, etc., etc. And then the data will be released for this research purpose. And hospital authority in Hong Kong, they also have a big data lab, and totally charged by the hospital authorities itself. So if you submit your research protocol and then you have been get a seat there, so you'll be able to access the data from the central data lab. So that is another option of doing analysis. And nowadays, hospital authority and the others, they also arranged the private companies. So they are doing this for commercial use as well. So the mission of Hong Kong government just to use the data as much as possible. So it's also open for commercial use. And so there are multiple routes of access the data. And as I mentioned, sorry, my network is bad just now. I mentioned that another way of doing collaboration is that we're doing the common data model. Common data model is that means we standardize all the data into a certain standardized structure. And then all the different centers can use the same set of statistical code to run it together to get to this is going to be very efficient. But at the very beginning, you have to spend major efforts in doing the OMOP, so-called OMOP exercise of the database. You have to standardize the variable names. You have standardized all the treatment patterns. Yeah, etc., etc. Once we pass that stage, and then the code has been passed the pilot stage from each set, then it will be much easier. So close communications between statisticians of each team is very important. So that's why I want to highlight manpower and capacity building is important. I don't know how many talent we needed here, but I think the more, the better. Yes.
Definitely. Maybe for China and Japan, probably the case is we have too many databases at the moment. So just talking about MDV earlier, I would say that this is governed by medical data vision. And another database that I mentioned earlier was JMDC. This is again data from all the annual health checkups from healthcare associations. So these data are, privately governed by like respective organizations. Maybe Jinan, is there a single organization within China? I think it will be pretty much impossible, probably covering, to cover all the databases. So, yeah.
No, that's not the case as far as I know. So like different databases will, there are different organizations or companies that manage different databases. So I guess Kate can answer that question since she works on the linkage of different databases. Kate.
It's bound to happen. As I previously mentioned, our data is owned and managed by different custodians at both a state and federal level. So our custodians sit within various state government departments, and then we also have Commonwealth government departments that are data custodians of the federal data. So the Population Health Research Network has data linkage units that sit within the different states and territories and the national data linkage unit, but we're not custodians of the actual collections themselves. So you are still in a position where you're having to negotiate with each of the data custodians for the use of the data, and that is definitely one of the challenges. We are moving towards data assets where you have data that's pre-linked and sits within the one repository, and that's managed by the Australian Institute of Health and Welfare, and they're definitely making the linkage process more efficient and certainly the access to data process more efficient as well.
Thank you so much. And thank you so much, Zihong Sai-san. She's joined this session. She's the one who arranged and collaborated, and all the speakers. And thank you so much for all the speakers for your presentation on different RWA databases in respective regions. I hope all the audiences enjoyed the session. Thank you so much for joining. We hope that you, and we also encourage that you join the rest of the session of this conference. Thank you so much.
Thank you so much for having us.
Thank you.
Bye.